Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and joining me today, our regular guest, I guess now, medical director. What do we call you now? Are you like retired? Or are you what's it when someone's
That works for me. Aged and decrepit, or retired, or kind of incognito. I don't know. I don't know what to call it.
I prefer MD2, I think.
Dr. Dixon's joining us today. As of this recording, I guess I am now the medical director, and I have to think about how that sounds. Also joining us are Division Chief of Clinical, Nick Smith.
Good afternoon.
And before we get started with the meat and potatoes of the episode, quick disclaimer, got to get it out of the way. This is not a dissertation or in-depth examination of diagnosing ventricular tachycardia with 100% accuracy. That's impossible, number one. Number two, it's really not the point. We're going to discuss some real-world cases with messy and muddy courses. That's what we see in EMS. Oftentimes, there's some difficult decision branch points. Sometimes these probably should be easier than they are, but to avoid getting off track, our topic's going to be pretty darn specific. We're going to talk about the decision with the wide complex regular appearing tachycardia, VT versus SVT. How do we determine the difference? How do we pick our treatment course? And what are some of the recent lessons we've learned here at MCHD? And I got to give Chief Smith all the credit. Another good mnemonic. I like this one because it puts all the important puzzle pieces together. Cardiologists and electrophysiologists can argue about this point for days. So our goal is not perfection here. It's practical decisiveness. It's how to make the decision and act on it. So let's start with some definitions. We're talking about ventricular tachycardia. So let's think about some of the things in the bullet points that we have to hit. Rate's got to be greater than 100. Probably most times should be greater than 140 or 150. So hold that thought. Be really, really careful. QRS has to be greater than 120 milliseconds. The tachycardia is originating from the ventricles. That's the point. It's a ventricular originating tachycardia. Definition of sustained VT at the point of me putting this together, and there's been some changes in this since I learned it. Greater than 30 seconds is defined as sustained ventricular tachycardia. Monomorphic means there's a single morphology QRS complex, whereas polymorphic ventricular tachycardia, multiple foci, torsades being one of the more common variants that we talk about there. So VT versus SVT with aberrancy or pre-excitation. Because normal SVT that we see every day, paroxysmal SVT, often the AV-NRT variety, is fast and narrow complex. But if there is aberrant conduction or a pre-excitation pathway, then we see a wide complex regular tachycardia. So backing up a little bit, SVT with aberrancy usually means SVT with a pre-existing bundle branch block, either right bundle or left bundle. The pre-excitation variant, which is one of the more concerning ones when we think about treatment and potential downsides, that's SVT with an accessory tract. Most common one of those that we know and talk about is Wolff-Parkinson's-White, WPW, with the delta wave short PR interval. The His-Purkinje system is still conducting. We just have a fascicular abnormality, whether that's a left bundle branch block, a right bundle branch block, or an accessory pathway such as the bundle of Kent and WPW. Why is this so difficult, Dr. Dixon?
Yeah, I mean, it's so difficult because the shock or not shock, and let's talk about the tools you have in the tool, the quiver, the arrows in the quiver to address this, right? Number one, first and foremost, is we have electricity. It is time tested. It works great. You have to be careful with it, but it's the go-to in an unstable patient. There's other things we have, commonly adenosine and then amiodarone. We're going to talk about each one of those, but I think both of them deserve, particularly amiodarone, very thoughtful patient selection, because if we give that medication to the wrong person, we may potentially do lots of harm. And there's this thing out there that a WPW patient, if we give them adenosine, we block the regular conduction system, SAAV his Purkinje, right? We're blocking the node transiently. That accessory pathway is going to accelerate and degenerate into VT. I don't know that I've ever seen that. I love that WPW people come with their own diagnosis because I'm too dumb. I've never really actually picked it up on my own. Most of them know they have it, and we avoid those type of drugs. But those are the two I want you to start thinking about. And then we have to start, we're in the death and disability business, right? We have to start with stable or unstable, right? Unstable, so low blood pressure, systolic less than 90, plus some altered mental status, right? They have altered mental status. They look bad. They're hypoperfused, right? Their brain's not perfusing. They may be tachypnic. They may look unwell, right? We know what to do with that. If they have a pulse, we sync it. We have to sync the R wave, and then we cardiovert that, right? There's no question there. If they're stable, they're perfusing, they're mentating, then we have to think about those other options we have. We have medication options, but I'm going to steal one of Dr. Patrick's here and say, that's the time to put the safety net in place. So full rule of 15s, pads in place, and then pause and perform. And then go back, and I'll kick it back to Nick for if it's wide complex and how we sort out this Vtach FACT. So you have to set up the safety net, establish stability, not stable. That's easy. Sync it and shock it. If it doesn't have a pulse, start CPR, go down that algorithm to where we cardiovert, unsynchronized. Stable, put the pads on, think about your medications that we have in the quiver, but then we have to sort out if it's wide complex, is it SVT with aberrancy, or is it more likely to be VT? And I'm going to kick it back to Chief Smith and have him talk about V-Tach FACT, which is the mnemonic Dr. Patrick was talking about, to help us kind of refresh our memory on what makes it more likely that it's ventricular tachycardia.
I'm going to steal from Chief Smith real quick because, like all of my favorite episodes that we've had in the past, this one stemmed from an active conversation in my office, thinking about the best ways to educate, the best ways to remember, based on real MCHD cases. These are cases that we had in our own service. These are run reviews that we had with our own in-charge captain, district chief, high-performing paramedics that were in very, very difficult spots, trying to remember all the various criteria, the scoring systems. We know that there are multiple that exist. Spoiler, most of them have a sensitivity, specificity for identifying VT of somewhere between 75% plus or minus. So none of these scoring systems that people out there try to memorize really work all that well, at least well enough to devote all your time and attention to memorizing all these things. So as Chief Smith and I were batting the ball back and forth, he said Vtach FACT. And I said, what? What do you mean? And we were talking about some of the steps that you take in identifying whether or not you want to proceed with synchronized cardioversion, whether or not this is a situation where we want to think about adenosine, whether or not we want to do nothing and give the patient a highly monitored, very closely attended ride to the hospital. And so I said, what do you mean Vtach FACT? So I'll let Chief Smith take his mnemonic here because it's awesome and I can't take the credit for it.
Well, as much as I appreciate that and appreciate the credit, it really was a team effort to get this. And the acronym really came from going through multiple call evals, run reviews, where we've identified that this is a difficult thing for providers to identify in the field. You talked about how it's difficult for electrophysiologists and cardiologists and how there's debate back and forth, and to expect our providers to go through and correctly identify that amongst all the other various stimuli and things they have to do is rough. So really this came about from watching those case reviews and learning through myself or through you and applying that myself to this Vtach FACT. So just to run through the quick overview, as we love our mnemonics in EMS and medicine as a whole. FACT, F is for fusion or fusion beats. A is for AVR or age. C stands for capture and consistency. And T stands for toxins. So like you said, not a 100% identifier, but a more quick way and a summarized way to put those key points together when you're trying to identify between the two when you're looking at Vtach versus SVT with aberrancy. Now, with fusion, so with your fusion beats, is much more likely to be a Vtach rhythm when you have fusion in there. So the ventricular muscle is depolarized by the SA node, and you have that ventricular beat. You form this hybrid beat. That's something to watch out for. If you see that, you should start leaning towards and thinking ventricular tachycardia.
Picture's worth 1,000 words here. We'll link up some PDF resources in our show notes. Really, a fusion beat describes what it is. It's not a wide VT beat. It's not a normal PQRST. It's somewhere in between.
I love it. The way I think about this, when you think about a ventricular tachycardia, right, it's coming the wrong way. So all it's doing is colliding. A fusion beat is nothing but the collision of a native beat that's trying to get through the regular SA AV His Purkinje, and it crashes with the ventricular beat that has come from the wrong nasty place and going the far rightward axis direction. So you come up with this nice little perfect, oh my gosh, that looks like VT. And then you see this thing in the middle and you're like, what is that? That's a fusion beat.
So if you see a fusion beat, odds are exceedingly high you're dealing with VT. For the MCHD medics out there, I'll go even farther. If you have a wide complex, regular appearing tachycardia and you see a fusion beat, for our service's sake, that's VT until proven otherwise.
I would agree with that 100%.
Absolutely.
And the only difference between that, and I don't want to steal your thunder, between a capture beat is the capture one just snuck through and it looks normal. It didn't collide with the ventricular beat.
So preview of C, before we get to C, let's hit A, because A is an important one, I believe, because there's two pieces to A.
Yeah, so A, again, you have AVR and you have age. So with AVR, if you have a positive vector in AVR, you have that high northwestern axis, that electrical conduction is going to the right shoulder in that is, 90% specific for Vtach?
And to go back to Einthoven's triangle and to think about where your leads are, I'm not an electrophysiologist, and that concept still requires me to repeatedly relearn. But the EKG is just a camera looking at an electrical vector from different perspectives. And so even if you don't know where any of the other perspectives are from, and the precordial leads are probably the easiest because they're just looking at the electricity directed towards the precordium where you place V1 through V6. But AVR is a camera perched up on your right shoulder of the patient. And if the positive electrical vector of the QRS complex is directed towards the left shoulder, it had to start, like Dr. Dixon said, in the bad place, and it's moving
in the wrong direction.
In the wrong direction. 90% specific. So like everything we're going to discuss today, not 100%, but if you go through V-Tach FACT and you think fusion beats and you see one, you're probably done. If you look for AVR and it's positive, you're probably done. You're in the 90% chance of being right. I don't want to be wrong with VT. Probably a good place to start. What's the other half of the A?
Yeah, so the other half is age. So with your older patients, they are going to be more likely to be experiencing Vtach in these specific situations as opposed to SVT with aberrancy.
They are older, sicker hearts, more likely to have a short, more likely to have plumbing problems, leading to electrical problems. Patients greater than 65 with a wide complex tachycardia, really, unless they're,
it's like calling a 65-year-old with shortness of breath and wheezing strictly asthma and giving them epinephrine. Be cautious.
Yeah.
Be cautious, right? There's lots of other bad things as we age. Lots of other nasty things come into play here, and it's not quite as clear of a picture.
I think another good analogy is ST elevation in a 65-year-old is not benign early repolarization.
Yes.
That's an acute occlusion.
Right.
So fusion beats, AVR, positive, bad, age, high, more likely VT. Hit the C, and Dr. Dixon already gave us half of the C.
Yeah, Doc, you talked about the capture beats, those occasional SA node beats with those wide complexes. We're looking at Vtach. Pretty straightforward. Capture and fusion beats are often absent in higher rates.
So that makes those tough. You squeeze those, you start to squeeze into that 170, 180, 190 range, and there's just not enough room in between to see those. But they should be on our mind, because if you see a fusion beat or a capture beat, you're in pretty good confidence you got a ventricular tachycardia. talk about consistency, because this is probably the part of the mnemonic, Nick, that you and I struggle with the most.
Yes.
Because concordance and disconcordance, two of my least favorite words in all of EKG interpretation, get used here as well, and it always confuses me. So how do we come up with our C that's not concordance?
Yeah, it's not concordance, it's consistency. So is the precordium consistent, right? So is it either, just to keep it, excuse me, simple and avoid your two words, I won't even say them, is it all positive or all negative? And when you're looking at that, do you see the leads in the direction of the vector going all in that positive direction? Do you see it going in the all negative direction? And now it's 97% specific if no RS complex through V1 through V6, that RS complex is either positive or negative.
97%. We're in the range where I'm going to err on the side of caution and call that VT. So consistent, positive, consistent, negative in the precordium, it's VT.
Does anybody else have a problem with, like, when I'm looking at those, I totally agree, couldn't agree more. I'm trying to figure out sometimes at super high rates, which one's which way is it going? So all Chief is saying is it doesn't matter if they look all the same. Don't parse hairs on is this a little bit positive, or is this, which one am I looking at, right? Which up and down of the squiggly, the consistent fast squiggly am I looking at? It doesn't matter if they're all going this, they all look the same. That's likely to be VT.
That's
right?
a great point.
Because I think it's hard to tell which one's going positive, which one's going negative. Don't worry about that. They all look the same.
Yeah, give it the big picture overview. Don't, this isn't the time to pull out your magnifying glass and
don't get
look
your
at every
calipers
beat.
out here.
No.
Oh, you EKG geeks.
I believe that's a really good point, and that point also holds true with AVR. It can be hard when these get really
fast,
bizarre and
Tell
get fast
what's what.
to tell what's positive, tell what's negative, to be able to tell whether your vector's positive or negative in AVR. I would urge everyone, when we have any EKG discussions, your friend in this is Google Images and Life in the Fast Lane. This is a pattern recognition situation, and the more you've looked at, oh, that's a positive AVR. Oh, that's consistent concordance or disconcordance. Oh, okay, I've seen that before. You need to have some baseline level of experience looking at these, and no better way to find those than on the internet, and Life in the Fast Lane's one of our trusted ones. If you look through their library and you see your first one, now you have a foundation to draw from. So back to Vtach FACT, fusion, AVR and age, capture and consistency. I'm going to let you fill in the T of the Vtach FACT, and this is one of Dr. Dixon's favorite teaching points. So tell listeners the T and pass it to Dr. Dixon to give us some wisdom here.
Absolutely. Doc, you have talked about this extensively, so I'm more than happy to pass that torch to you. The T stands for toxins. And if you'd like to expand on that a little bit further, be happy to hear more.
So I think that we'll go back to pause and perform, right? Depends on the stability of the patient, right? An unstable patient, you're going to put the pads on and sync cardiovert that patient if they have a pulse. If not, they're going down the CPR pathway. That's fairly clear. Now we're looking at someone where there is some modicum of stability. We have time to put the safety net up and try to sort those out. And why are we spending time on toxins? Because lots of toxins can cause a wide complex in sick patients who may have a compensatory tachycardia. There are toxins out there like potassium, like sodium channel blockers in overdose that can widen the QRS in a wide complex regular tachycardia, maybe a sinus tachycardia with a toxin with hyper K. So how do we sort those out? And part of it is looking through the right lens, right? And we're going to stay tuned. Casey's got another episode coming up that's going to focus on those categories of when we look at EKGs to look through the right lens. So in this particular one for Vtach FACTs, we're looking kind of strictly through the ACLS lens, aren't we? But when we get to toxins, we have to think through a different lens, and it depends on the patient presentation. Remember, every EKG goes with a patient. Did the patient present with altered mental status and found down and unknown what happened to them, and a wide complex tachycardia, which is much different than the crushing substernal chest pain, or I feel weak and dizzy, I felt fine, and now I'm sweaty and I can't breathe, right? That's a much different story. Or the patient that maybe has a dialysis catheter and has been unwell for a few days and missed dialysis and presents with this really, really wide, bizarre but regular tachycardia. So those are the hard ones to really sort out. And I will say, we're never going to go wrong. We're not going to hurt patients in those types of situations with treating with some sodium bicarbonate and calcium, right? That is not going to immediately harm them. Whereas if we go down and strictly look at these from an ACLS lens, if we give, say, a multimodal channel blocker like amiodarone, right, that could be very, very problematic. And I'll refer to the show notes to someone much more adept in this topic than myself, Dr. Matu, who lectures extensively about his case experience with really, really wide complex tachycardias and how to sort these things out.
If you have interest in this topic at all, we'll link the 9-minute in length YouTube video that I watch probably 2 or 3 times a year, where Dr. Matu talks about really wide regular tachycardias and the danger there with sodium channel blocker overdoses and hyperkalemia. Because when we go back to our definitions, VT by definition has to be greater than 120 milliseconds. Small boxes are 40 milliseconds. Large boxes are 200 milliseconds. The wider the complex is, the more likely it is to be VT to a point. Once we cross that 200 millisecond one big box threshold, we have to have an internal alarm bell to think about regular, really wide complex tachycardias, and just pause for a second and consider, hey, how fast are we? What's the surrounding situation? What's the patient look like? And before I fire up some amiodarone or even some electricity, would calcium and or sodium bicarbonate be a reasonable option? And I agree with Dr. Dixon. Neither of these have large harm risks. Yeah, calcium can make you a little nauseated. We don't want it to extravasate. I get that. Sodium bicarbonate comes with the volume issues with a large sodium load. But in these situations, I feel like the benefit drastically outweighs the risk, and we don't have to wait around to see whether we're right or not. If a patient has hyperkalemia and or a sodium channel blocker overdose, and we give calcium and bicarb, it's not going to take 2 minutes, 5 minutes. It's going to be seconds. And
diagnostic and therapeutic. And conversely, on the other side of that equation, we can do a lot of harm. I'm not an anti-amiodaroner. I don't know if that's a word, but we can do a lot of harm, right? We give that medication to a really wide complex, and I have seen this. We've seen it in our own service. We have seen it in the hospital. We've seen it in M&M many, many times, where we are confronted in emergency services with a sick patient, and we jump to the lens that we're most familiar with. That patient gets amiodarone, and they destabilize and go into VF, or can have a bigger propensity to stabilize. So not going to hurt them in the near term if we're wrong with calcium and bicarb. If we're wrong with amiodarone, we can really hurt folks.
Let's talk about a couple of the cases and finish up with some, I wouldn't say dogma, but just some common thought that's out there that I would like to just toss around for a bit for the last 5 minutes. A couple of these cases that we had, I want to be very clear to the medics out there from MCHD who are listening. If you had these cases, and you probably will listen to this because I'll ask you to, these were tough. This is not a situation where any of this is a slam dunk. The idea being that it's never as simple in the real world as it is when we discuss this. We had a patient in their 60s with upper respiratory symptoms that caused them to present with tachypnea, systolic blood pressure around 100, sats in the 80s. Heart rate was in the 180s to 190s. And that's not easy. Is this sepsis? How did this start? It was acute, but not terribly acute. But the patient was older. There was a blood pressure that was, definitely on the borderline for someone with a heart rate in the 180s to 190s. Sats were in the upper 80s. So, is this a pneumonia or a sepsis? AVR was clearly positive, markedly positive. So using Vtach FACT and stepping back from the patient a little bit, that's not an adenosine patient in my book. We've got sats that are borderline. We've got blood pressure that's borderline. We've got an older patient with very significant rate elevation. This wasn't a compensatory sinus tachycardia. We were up to almost 200 and above 200 at some times. But it's not easy. I mean, that wasn't a straightforward case. Younger patient in their 40s presents with shortness of breath, altered mental status, and symptoms concerning for a GI bleed. It's hard.
Yeah.
Rates, how fast were the rates? Nearly 200. AVR was positive, and the precordium was entirely consistently positive. So if you go back and you apply Vtach FACT, there were no fusion, there was no capture beat, age wasn't there, younger patient, but AVR was positive, and the precordium was consistent. But man, tough, right?
These are super tough, but I think it really goes back to, we have these discussions, and this is really, really hard stuff. This is in the retrospectoscope, makes it look easy here. In the real world, when we're confronted with someone, when we walk in the door, we have no idea other than what their call designation was, right? We don't know any of this that we know now, right? Where does it go back to? Recognizing stability or instability and set up that safety net. Buy yourself some time to sort it out because these things live together. Can you have secondary Vtach because you're in septic shock? You absolutely can. Can you have an exsanguinating GI bleed and you get anemic and get Vtach? You absolutely can. So give yourself some time. When you set up that safety net, you buy time to help us sort these things out in a rational way and then come up with the best way. Which came first, the chicken or the egg, and which direction should I go first? Because I have that safety net there. If they say boo, sink them and shock them, right? We have everything in place. It takes a moment. We can start addressing maybe where we think the instability is coming from, address their hypoxemia, address their shock state, and then if they don't settle, then we can, or they get worsened, we can always shock then. I think sometimes we jump and we go, oh my God, it's why it's VT. And we totally put blinders on and miss the fact that they've had a fever and they're hypoxic. And there may be lots of other reasons, plus the wide complex that they're in shock.
Yeah, this is a larger clinical picture. And I entirely agree with having your safety net in place for the MCHD medics. This is your moves. This is your rule of 15s. These are the things that we've trained on, we've practiced with, we've gone through scenarios to set you up, to give you that time and to give you that opportunity to get your larger view of that patient and really take that into consideration. This FACT is just another tool in the toolbox to help with the specificity in those cases. But regardless, moves, rule of 15s, that still applies to these patients.
Yeah, and I guess I have to explain myself a little bit here. We reviewed these calls, and realistically, my end teaching point was these are really difficult. These are sick patients. Both of these patients were, in my view, of the unstable variety, and in both cases we resuscitated the patient. I would have moved to cardioversion synchronized in both of these patients. What we did in both of these patients, however, was start with adenosine. And so that led me to think about, well, what about adenosine? Isn't it okay in monomorphic VT? I've had sharp EKG savvy medics ask me that. I've had residents ask me that. I've heard my partners say that for the better part of 20 years now. Adenosine is safe in VT, right? And when you read about that, and you go to the textbook or you go to a review article or you look at anyone's slides online, they're going to cite the same study, which is always interesting to me when things get passed down over time in that telephone game. And if Dr. Marill is listening, no knock to Dr. Marill, but let's look at the study. Marill et al., Critical Care Medicine, 2009, so about 15 years old. And what they did was they looked at 15 years of experience giving adenosine to wide complex tachycardias. Over that 15 years, only 200 folks qualified. So this wasn't a 2,000, 20,000 person study. This was a 200 patient study. And what they found was that if the patient converted, they were 36 times more likely to be SVT. Not something that should shock anyone. If there was no effect, they were 9 times more likely to be ventricular tachycardia. If the focus of the origination of the beat comes from the LV and you give someone an AV nodal blocker, it should not, theoretically, convert that into any other rhythm. It should just be ineffective. So they found what we thought they would find, and that is that if it breaks, it's more likely SVT. If it doesn't break, it's more likely VT. But here's the problem. It's 200 patients. It's a couple hundred patients in each group. And they didn't have any patients documented in the study with SVT and aberrancy from a pre-excitation pathway. There were no WPW patients in this study. There are multiple case reports of VF following adenosine and WPW. So can that happen? Yes, it can. Is it going to be rare? Yeah, it's going to be rare, but I don't want to be the one.
Yeah, my question would be, how many of those patients I'm not as adept at research as Dr. P, but I'm just going to break this down for us regular people here in the room, which is we gave them a medicine we think it's SVT with aberrancy. We gave them the medicine. Yep, if it worked, it's SVT. We sent them home. But how many of those people in this study got a confirmatory study to prove with an electrophysiologist follow-up or any follow-up? The answer to that is none of them. We don't know, because if they converted, we sent them home and said, yep, it's SVT. That was the gold standard, which that's not really a gold standard in my view. So I'd say if you look at all the big guideline-driven things out there, most of the ones that we really hang our hat on in stroke, in STEMI, in resuscitation, and the things that we do have tens of thousands of patients in these large registries. Be a skeptic, guys. This is less than 200 patients. I'd say be very, very careful with wide complex tachycardias, giving them adenosine. I'm not a fan. I've never been a fan of this. This came up, someone brought this up probably 10, 15 years ago, and I actually looked into this study, and I was like, oh my gosh, this recommendation, because I didn't believe the rec when it came out, and how little patients it was. No knock on the AHA. I just think that, for someone that's so sick and so difficult and undifferentiated, we're spending all this time talking about it, that maybe we shouldn't change our practice over 200 patients.
Like anything, my answer is not always and rarely never. And so I would not go so far as to say that I could not envision a situation to where I gave one of these patients adenosine. I would almost guarantee you, number one, that I would have cardiologist input, and number two, I would have the monitor printing the entire time so that I had visualization of the adenosine effects. I think that is absolutely positively vital, so that if you do convert them, you have the before to show the electrophysiologist, the cardiologist, to make sure that you don't miss, even if you are lucky enough to convert a VT with adenosine, so that you can have the evidence and they can get an AICD or an EP study or whatever they need down the line. Before we wrap up, there is one last piece, and that is we did not talk about calcium channel blockers and the role of calcium channel blockers in SVT in this discussion. It's too much for today. We don't carry calcium channel blockers on the trucks here at MCHD. So if you think I left that one out, I did, and that was on purpose. So let's wrap it up. Most wide complex tachycardias, depending on where you look, somewhere upwards of 3/4 are VT. So if you're hemming and hawing and unsure, if you go with VT, you're probably going to be right more times than not, and you'll definitely be prepared 100% of the time, which is key. Unstable, wide complex rhythms get shocked. Pretty straightforward. V-Tach FACT, fusion beats, F, age and AVR, A, C, capture beats, and consistent precordium, all negative, all positive. Don't forget to think about T. While toxins aren't going to diagnose Vtach for you, if you have a wide complex tachycardia, especially a slower one, less than 150, especially a really wide complex, greater than a big box, greater than 200 milliseconds, we have to think about sodium channel blockade and hyperkalemia. Calcium, bicarb, they don't kill anyone. They may have some mild complications. Amiodarone in a patient that's overdosed on flecainide will kill them. A clean kill, as Dr. Matu would say. So thanks, Nick, for your time in thinking about how we can better educate our medics, how we can apply this to our own cases and our own education here at MCHD. Appreciate your hard work and the rest of the clinical team's hard work on this. Dr. Dixon, thanks for joining us. You guys have anything you want to add before we wrap up?
No.
That's it. Thanks for having me.
No, great for having me back, and it's great to be on the cast another time. Like it.
As always, if you have questions or concerns, please email us, podcast@mchd-tx.org. Follow us, subscribe, leave likes, lots of stars. We appreciate the feedback. Watch us on YouTube, subscribe on YouTube as well. And if you leave a comment, I will reply almost all the time. So thanks again to Dr. Dixon and Chief Smith for joining us. Thank y'all for listening. We'll be back with another episode soon.